Hey dear class, this is part 2 of insulins and oral hypoglycemic agents. So this part talk about the oral agents. So these agents are useful in treatment of patients who have type 2 diabetes but who cannot be managed by diet alone. Patients who have developed diabetes after age 40 and have had diabetes less than 5 years are those most likely to respond well to oral glucose lowering agents. Insulin is added because of progressive decline in beta cells that occur due to disease or aging. All glucose lowering agents should not be given to patients with type 1 diabetes. So example here you have the shortest duration the glinides. Glinides have the shortest duration of action. Then the longest duration of action are the glitazones. Glitazone. And probably the most common drug that you see patients taking in clinic, probably metformin. That is one of the biguanide or one of those glyburide, glipizide. Those are the sulfonyl urea. And we'll go further. Sulfonyl urea. These agents are classified as insulin secretagogues because they promote insulin release from beta cells of the pancreas. The primary drugs used today are second generation drug glyburide and glipizide and glimepiride. So stimulation of insulin release from beta cell or pancreas by blocking the ATP sensitive potassium channel, resulting in depolarization and calcium influx. So it increases the insulin release, and it can also reduce hepatic glucose production and increase the peripheral insulin sensitivity. The shortcoming of the sulfonylurea are their propensity to cause weight gain, hyperinsulinemia, and hypoglycemia. So hypoglycemia is a major concern. This class of agents include ripaglinide and nataglinide. Although they are not sulfonylurea, they have common action. They bind to a distinct site of the sulfonylurea receptor of ATP sensitive potassium channel, thereby initiating a series of reactions culminating in the release of insulin. So this class have short duration of action. Insulin sensitizer. This agent lower blood sugar by improving target cell response to insulin without increasing pancreatic insulin secretion. Metformin, the only currently available biguanide, is classed as an insulin sensitizer. It increases glucose uptake and use by target tissue, thereby decreasing insulin resistance. The risk of hypoglycemia is far less than that with sulfonylurea agents. Another group of agents that insulin sensitizer are the thiazolidinedione, also called glitazone. Although insulin is required for their action, the drug do not promote its release from the pancreatic beta cell, so hyperinsulinemia is not a risk. The two members of this class currently available are pioglitazone and rosiglitazone. They are known to target the peroxisome proliferator activated receptor gamma, a nuclear hormone receptor. Ligands for PPAR gamma regulate adipocyte production and secretion of fatty acid as well as glucose metabolism, resulting in increased insulin sensitivity in adipose tissue, liver, and skeletal muscle. The ADA recommends pioglitazone as a tier 2 alternative for patients who fail or have contraindication to metformin therapy. Rosiglitazone is not recommended due to concern regarding cardiac adverse effect. Abacos and miglytol are orally active drugs used for treatment of patients with type 2 diabetes. These drugs are taken at the beginning of the meal. They act by delaying the digestion of carbohydrate, thereby resulting in lower postprandial glucose level. Both drugs exert their effect by reversibly inhibiting membrane-bound alpha-glucosidase in intestinal brush border. This enzyme is responsible for the hydrolysis of oligosaccharide to glucose and other sugar. Consequently, the postprandial rise of blood glucose is blunted. Sitagliptin and saxagliptin are orally active dipeptidyl peptidase 4 inhibitor used for treatment of patients with type 2 diabetes. These drugs inhibit the enzyme DPP4, which is responsible for the inactivation of incretin hormones such as glucagon-like peptide 1. Prolonging the activity of incretin hormones results in increased insulin release in response to meal and a reduction in inappropriate secretion of a glucagon. All glucose results in a higher secretion of insulin that occurs when an equal load of glucose is given intravenously. This effect is referred as an incretin effect and is markedly reduced in type 2 diabetes. The incretin effect occurs because the gut releases incretin hormone, notably glucagon like peptide 1 and glucose-dependent insulinotropic polypeptide in response to a meal. Incretin hormones are responsible for 60 to 70% of postprandial insulin secretion. Exenatide and liraglutide are injectable incretin mimetics used for treatment of patients with type 2 diabetes. This agent may be used as an adjunct therapy in patients who have failed to achieve adequate glycemic control on sulfonylurea, metformin, or glitazone, or a combination thereof. Here's just a summary of notable side effects for the different classes of glucose-lowering drugs. So for the sulfonylurea and gliptinides, remember hypoglycemia. For biguanides and alpha-glucosidase inhibitor is more gastrointestinal disturbance, and for biguanide it's more of nausea, and for the glitazone or thiazolidinediones cardiovascular risk. Okay, so here's just the table, just summarize all the different drugs that we talk about to lower blood sugar for diabetic patients. And the last one here is diabetic management. So this is the clinical guideline.